My name is Randy Kojima, and I'm the Director of Technical Affairs for Precision Technology Services. I'm excited tonight to share with you some myopia control tools that you could have at your practice in contact lenses to try to control the progression of myopia in kids. Tonight's webinar is sponsored by Precision Technology Services in Vancouver, Canada, and also by Bausch & Lomb and the Boston Lens Group. So tonight I'd like to start with a story about my daughter, actually, and how concerned I am as a parent about her potential progressing myopia. And we know that she should be she should achieve emmetropization somewhere around 6 years old. So if she were to become a emmetrope or even a myope before that 6-year period, then I'm going to start looking a lot more carefully at things I can do to keep her from progressing. Now, why would I be concerned? Her mother's a 6 diopter myope, a high myope, and father's a -8 diopter myope. If a child has one myopic parent, their child is 2 times more likely to be a myope than a child without any myopic parents. A child with 2 myopic parents is 5 times more likely to be a myope than a child with no myopic parents. So this child has a very good chance of becoming a high myope. Now we know that the average myopia progression per year is approximately a ½ diopter, and that's been backed up numerous ways in numerous studies. So therefore, an 8-year-old patient with -1 diopters of myopia progressing at that -50 per year would become a 5 diopter myope by the age of 16. Now, why would we even worry about a patient that's a high myope? Why not just continue to dispense conventional glasses and contact lenses for these patients? Well, we know that the higher the myopia, the greater the likelihood of premature cataracts, premature glaucoma, retinal detachments, and macular degeneration. So it's important that if we have an ability to reduce the progression of myopia, that patients may benefit significantly in the later years of their life. So being cognizant of the progression that we're seeing with our kids is very important. Noel Brennan looked at what would be considered high myopia. At what level do patients enter a riskier state for either retinal problems, for cataract problems, for possible glaucoma? And he felt that 5 diopters of myopia would safely be considered high myopia. Now, he also calculated that if we could reduce myopia progression by 33%, that would eliminate 73% of the high myopes. If we could reduce the progression of myopia by 50%, it would reduce 90% of the high myopia, the myopia above -5. So with some treatments that could possibly keep this progression under control to a certain degree, even by as little as 50%, that might eliminate 90% of the high myopia. Now the question is, do we have the tools to do that, to control 50%? And that's one of the things we'll discuss tonight. We know the incidence of myopia in the Western world is moderate in some developed nations in Europe, but is fairly significant in North America, and certainly in Asia it's considered an epidemic, up to 80% in Hong Kong. In other words, 80% of children have myopia in Hong Kong today. China's very close at 78% based on recent studies, and you can see throughout Asia it's fairly high. In the US, for instance, the FDA has been monitoring the progression of myopia and found over a 30-year period, up until I believe it was 2011, there was a 66% increase in the USA or in North America alone between 1971 and more recently. So progression in all of the Western nations, we're seeing myopia just shooting up. And the question is, why is it happening so quickly in our environment today? Now, Don Moody at The Ohio State University has been looking at light and its influence on myopia progression. And he's found that the vitamin D levels in myopes tend to be about 20% lower than in non-myopes. So somehow vitamin D may be a link to why some of the kids are progressing more and some less. And he also found that there was a significant shift between the vitamin D levels in children between summer and winter, which would seem logical based on the amount of light that we're receiving between the two seasons. Now, he hypothesizes that there is some kind of retinal signal, or the signal by the dopamine or the vitamin D, that creates this block that encourages the eye not to grow? Or is there some retinal signal that is sent to the system that keeps the progression down to a certain degree, and that somehow this outdoor light seems to create that signal that keeps the progression from being as significant as it might? Although he does note that outdoor activity appears more inhibitory before myopia onsets. So once myopia is happening, the outdoor activity or outdoor light appears to be less of a factor. So the more we have kids outdoors early in their years may be the better for encouraging that myopia control to a certain degree. And this isn't unique just to the Ohio State University. In China, they found that there was a significant difference in the progression of myopia between summer and winter. In fact, the summer progression was 60% that of the winter. So if the patient progressed by a factor of 1 throughout the winter, the summer progression was 60% of that growth. So eye growth really changes throughout the year. The less the light, possibly, the greater the progression. The more kids are outside in the light, it appears, the less they progress. Now, this was also found in Denmark as well. So we've gone through North America, through Europe, and now, through Asia, and now we're in Europe. And in Denmark, the light varies from as little as 7 hours in the winter to as much as 17 hours in the summertime. And the Danish researchers found that the progression of myopia was much less during the summer months when there's so many hours of light. Is it tied to the amount of light during the day? Is it tied to the fact that the kids are outdoors much more? Might be the combination of the two, but certainly the progression was less in the summertime. So light is somehow a factor. So a number of studies are suggesting to us that one of the most powerful mechanisms that we can use to control youthful myopia progression is to have kids outdoors for 2.8 hours a day. That seems to be the golden number. The longer we can have kids outdoors, the better that is for reducing the progression. And as an example, if you measure indoor light, or measure light in lux, or its luminance, indoor light is measures about 50 lux. In the direct sunlight, it's about 50,000 lux. Even on a shady day, it's 2,500 lux. So it's somewhere in the neighborhood of 50 times the amount of light intensity, even in a shady day, compared to the amount of indoor light. So light is a factor somehow, but as Dr. Moody suggests, it may be a factor before myopia onsets, whereas after onset, light seems to be less of a factor. So what are our options then? If a child is becoming a myope, if the child is prematurely an emmetrope, or if the child is progressing very radically in their myopia, what do we do? And over time, we've had a number of options presented to us. We could ignore the amount of myopia increase and just continue to dispense glasses and contacts. We could undercorrect. It's been suggested that progressive addition lenses have some effect. There's pharmacological intervention. We have orthokeratology. For about 10 years we've known that it has some effect, and more recently multifocal contact lenses. So let's go through the group of them and see if we can come to some understanding of what may be beneficial here. Now, one of the things that I'd really encourage you to do is look up the work of Dr. Earl Smith. He's the Dean of the University of Houston. He's been doing some really amazing work with primates, and Earl has suggested that there may be a mechanism for the myopia progression, and his work would suggest that it's the peripheral retina that plays a major role in our progression of myopia and eye growth. So I would strongly encourage you to look up Earl Smith III at the University of Houston and some of his studies. If you happen to be at any international or even regional conference where he's speaking, I would not miss a lecture by Earl Smith. Now, let's go through some of the work and tie this back into Earl's studies. And one of the things that was suggested early on in my career was that if you undercorrected the myope, that may not create the cascade of increasing myopia. But a number of studies have shown us that if we undercorrect the myope, it actually works against us. We get more myopia progression in an undercorrected myope than we would if we fully corrected the myope to the fovea. So undercorrection simply does not work. Now, one of the things that you look at is when light rays either land in front of the retina or on the retina, there may be this peripheral retinal hyperopia. And Earl's work would suggest that when the light rays land beyond the retina and you have hyperopic defocus, that creates a signal for the eye to grow. So regardless of if you have foveal correction or undercorrection, it's this peripheral refractive error that seems to be the signal for the eye to grow. It's suggested that possibly the peripheral retina wants to be more involved in the optical system and desires to have light land in that area. When light doesn't land in that area, the eye changes shape to appropriately focus the light rays on that peripheral retina. Now, if we correct the foveal myopia, that may continue to create that hyperopic defocus, and it makes sense. The more we push back the foveal correction, the greater the hyperopic defocus becomes. And that may be why there's this vicious circle of chasing a half diopter continuously throughout an adolescent's life, because we continue to increase the hyperopic defocus. Now, the question would be, in conventional glasses, do we have hyperopic defocus? And a number of groups have looked at the amount of peripheral refractive error with conventional spectacle lenses. And what they found was that you will have foveal correction in the center, but you have this hyperopic defocus in the peripheral retina with conventional glasses. So single vision lenses may be working against us in our young kids, in these progressing myopes. Now, a question would be, what about soft lenses? Could we use conventional soft lenses in the correction of this peripheral refractive error? And a group in the University of New South Wales, Pauline Cheng Helen Swarbrick and group, looked at 3 different types of correction. They used a soft lens to correct the foveal error, to undercorrect, and to overcorrect. So they used 3 different correction of lenses on their study patients. And what they found is no matter which lens they used, they had this hyperopic defocus in the peripheral retina. So no matter what we did at the fovea, it really didn't matter. We still had hyperopic defocus. And again, it's that hyperopic defocus that may be the signal for the eye to grow. Now, what about progressive addition lenses? That's also been studied, and it's been found that it had some effect. Patients in progressive addition lenses had 16% less myopia progression than the control group. So there was some influence by either the relaxing of the accommodative mechanism or by introducing some plus into the system and possibly moving light rays forward of the retina. In a study in Canada by Cheng in 2010, looked at using executive bifocals versus single vision lenses, and they found in their single vision lens group the average progression was about 1.5 diopters. Using a 1.5 diopter add, they found the progression in their executive multifocal group was about 1 diopter, and then if they used a executive bifocal with 3 diopters of base in prism, they found even less progression. So there is something to do with how we're bending the light that may affect the progression of myopia in our kids. Now, one of the methods that was long believed to be very powerful in the progression of myopia as a tool to keep kids from increasing in their nearsightedness was to use single vision conventional RGP lenses or alignment fitted RGPs. And would that somehow keep the eye from growing? Would that keep the myopia from progressing? And 2 very significant, very large studies looked at alignment fit RGPs and found that they actually worked in reverse. The kids in the GP lenses actually their eyes grew longer than the control group eyes. So RGPs as a tool, conventional RGPs, as a tool to control myopia progression, we cannot say that it's effective at controlling eye growth. Now, one of the problems may be when you do a topography over top of an RGP lens on eye, you can see this beautiful spherical blue shape across the entire anterior surface. And if you look at this cross section here, the white line, notice how the eye has basically 1 radii of power, or the anterior surface of our GP lens has 1 radii. It's very spherical. So imagine you have the appropriate foveal correction, but we're pushing the light rays behind the retina by not creating more plus as we move away from center. By having that perfect spherical shape, it's just like putting a patient into conventional glasses because we're not moving light rays forward of the retina. We're creating hyperopic defocus. Now, why is it that RGP patients often would not progress in myopia? Is there something else at work here? And take this case where we have a patient before RGP lenses in 2003 and after RGP lenses 8 years later in 2011. And when you compare the topographies before fitting and after fitting, you can see you flatten the cornea a fair amount to the tune of about 1.5 diopters. So is it true that our RGP lenses have just by fluke, by fitting a centered or slightly lid attached RGP fit, we've slightly flattened the cornea out, which has given some of these patients a almost ortho-K type effect, or like a refractive surgery type effect, where we've reduced the myopia to a degree, and that's giving us less progression of myopia, even if the eye is elongating. So RGPs may be molding the cornea more than they were ever keeping the eye from growing. Now, at about the same time that the Katz and the Walline Spherical GP Lens study came out that showed us that conventional RGPs do not control myopia progression, Pauline Chau at the Hong Kong Polytechnic University came out with her small pilot study using Ortho-K lenses on their kids, and she found some very interesting things. That her Ortho-K wearing kids had basically half the progression of myopia after 2 years of wear. So although conventional RGP lenses had no control of the myopia progression, Ortho-K lenses appeared to have 50% less the vitreous chamber elongation that the control group had. So there appeared to be something with Ortho-K that wasn't happening in spherical or alignment fit RGP lenses. Now this may be answered in some of Earl's work, and we'll keep referring back to Earl Smith's work, where in orthokeratology you create the most effect in the center, whereas it gradiates out as you go toward the periphery. So more myopia effect in the center and less as you go toward the periphery. And that may be creating foveal correction to give us the ideal quality of vision, but in the peripheral retina we're moving the light rays forward because there's less effect toward the peripheral retina. And is this somehow the signal that keeps the eye from growing by distributing the light rays across the retina more evenly? So Jeff Walline at the Ohio State University did an Ortho-K study to follow up Pauline Chau's work. So we have one study out of Hong Kong that showed that Ortho-K wearing kids had half the progression of the control group, and Jeff Walline, who had done that very big RGP study to look at conventional RGP lenses and whether they would control myopia progression, he found they didn't. So he decided, well, let's check out Ortho-K lenses and see if I can find the same results that Pauline had. And sure enough, Jeff's work at the Ohio State University found exactly the same thing, that kids in Ortho-K lenses had half the progression of vitreous chamber depth that the control group had. So there is something to Ortho-K lenses that keeps these eyes from growing as aggressively. Now when you look at eye shape before we do any treatment, you see that the patient has most minus in the center of the topography, most curve, and then as we move away from center, the cornea gets flatter and flatter. So we're actually going in the wrong direction. If we want to create more peripheral retinal myopia rather than peripheral retinal hyperopia, we need the eye shape to get steeper as we move away from center. But in actuality, our natural eye shape, the prolate eye, gets flatter as you go away from center. By comparison, when you do Ortho-K, you create the reverse. You create most minus in the center and then plus toward the outside. You create less minus or more plus, however you want to think of that. But what you're doing then is creating foveal correction, but moving the light rays forward as you move away from the center of the pupil. So this may be part of the mechanism that makes Ortho-K so successful for myopia control. Now again, let's look at the two of those cross sections, and the upper image would be the normal eye shape, steepest in the center, flattest toward the periphery. Not bending the peripheral light rays forward of the retina, actually pushing them back. However, when we do orthokeratology, we have most minus in the center and then increasing plus or less minus toward the periphery. And the idea would be this is your foveal correction, and then you're increasing plus, pushing the light rays forward of the retina. Now, when you do orthokeratology, you can compare pre-treatment shape versus post-treatment shape and see the change between the two. Most effect in the center, radiating out less effect toward the periphery. On the graph down below here, looking at this white axis line, you see that exact same thing. Most minus effect, and then increasing plus or less minus as you go away from center. So if we want a optimal type of myopia control shape, it appears that we want the bottom type image where you have this very aggressive ramping up of the plus very quickly. That will move the light rays forward of the peripheral retina. Having a very mild effect where you have very little ramping up of the plus may not be the optimal shape to actually move those light rays far enough forward of the retina to create emetropia in the peripheral retina or myopia in the peripheral retina. We don't want hyperopic defocus. That appears to be the signal for eye growth. So looking at the studies that have been done in orthokeratology, you can see that the average effect that we seem to be seeing is around 50%. That when we fit kids in orthokeratology lenses, their progression appears to be cut in half. Now, I should note that we cannot say, looking at any particular child, what their progression will be. When a certain family comes in with two myopic parents and their 6-year-old is a -1 myope, we can't say if doing orthokeratology is going to cut the astigmatism in half. It might, cut the myopia in half. It might progress 100%. We just simply can't say which patients will progress a lot and which patients won't progress at all. What we can say is the average progression when we put kids in orthokeratology lenses is, on average, they have about half the growth of the control group. So some patients won't progress at all, some patients will progress a lot. On average, it's about a half. Now, what about stability of the effect? And this was done by Laura Downey in Melbourne, Australia. And she looked at kids over 2 to 8 years, or until she either lost them to follow-up, they moved away, or discontinued ortho-K. And what she found was that the RXs were far more stable in her ortho-K group compared to her control group. What I thought was interesting was 64% of her ortho-K wearing kids had a complete arresting of their myopia progression. So 64% of the kids had no progression in their myopia. Now, another study that was kind of interesting in ortho-K was Hong Kong Polytechnic has been one of the epicenters of myopia research, and probably because Hong Kong's incidence of myopia is so high at 80%. And Jesse Charm and Pauline Cho at the Hong Kong Poly thought, well, what if we had a patient that's greater than -5 diopters and we're only able to achieve 4 diopters of ortho-K effect? What if we can only achieve a portion of the myopia in ortho-K? Would that still achieve a decent myopia control effect? Would ortho-K work when we can only control part of the, we can only treat a part of the myopia? So what they did was they took patients that were greater than -5 diopters myopia and targeted in the ortho-K lenses 4 diopters of effect. So they tried to achieve only 4 diopters regardless of if the myopia was 5, 6, or 7 diopters. Then they dispensed glasses during the day to make up the residual prescription. And what they found was that the axial growth in their ortho-K wearing kids was 63% lower in the ortho-K group versus the control. So it appears that even when we do partial ortho-K, if we have a young child that's progressing very, very rapidly, and we can expect to achieve a full 6 or 7 diopters of ortho-K, we can do partial ortho-K, dispense glasses over top, and we will still have a myopia controlling effect from the lenses. Now, is there another way to achieve this hyperopic defocus? Is orthokeratology the only way for us to treat myopia progression? And the answer is no. Zeiss has been looking at using glasses to using glasses to treat myopia progression. And in their study, they found that their MyoVision lenses, their patients had 30% less progression of myopia with these specially designed lenses that create that peripheral retinal change in focus, that hopefully emetropia in the peripheral retina, but not creating hyperopic defocus. So it was about 30%, which was reasonable. Now, what about soft multifocals? Could they be used to push the peripheral light rays forward? And the answer is yes, and there's actually a number of ways that it appears that we can do it. We can have most minus in the center and progressive plus toward the outside, similar to how an ortho-K treatment would be done. But also it was found minus in the center with concentric rings of plus may also be effective. So both designs were effective as myopia control tools, but it appears that what we need is most minus in the center in our soft multifocal lenses. If we take out the one study that was on a small n size of 2, the average that the soft multifocals appear to be able to control progression is about 37%. So they're fairly effective at controlling myopia progression. Now, what about GP lenses? Could we control myopia progressions with our GPs? And not every patient fits into a soft multifocal or a soft lens in general. What if the patient had progressing myopia but also had astigmatism that was outside the range of our soft multifocals? Then we could possibly fit the patient in a GP lens. And this would be to have exactly the same type of shape, most minus in the center, more plus toward the outside. So we have our foveal correction. As we move away from center, we push the light rays hopefully forward of the retina. And that would be a most minus center aspheric presbyopic type lens. However, with kids, we're using high ads, like +3 ads, to make sure that we effectively overcook the plus. We don't want the light rays landing behind the retina. We want them landing in front of the retina. So with our multifocal RGP lenses on our kids that may have more astigmatism, that soft lenses won't work, then we can create most minus in the center and then ramp up that plus as we move away from center very aggressively and very quickly. Now, what about pharmaceutical intervention? Is this something we can pursue? And studies have been going on in using atropine and pirenzepine for well over a decade, and this appears to be a very powerful tool in controlling the progression of myopia. It basically just knocks out the progression for the most part, or at least this early ATOM study suggested that it would completely knock out the progression of myopia. Now, more recent studies, now 10 years later, have looked at whether we could use smaller concentrations and have the same effect. So using both 1% atropine and 0.5% atropine appear to have the same effect. If we know the normal progression of myopia is about a half diopter per year, in the atropine study, it was basically 0.05 diopters per year. So why not use atropine for 100% of our kids? And the reason is there's many side effects that have been associated with using atropine, and we also don't know the long-term effects of putting kids in this pharmaceutical intervention over the long term. So that's led to using even smaller concentrations, and today there's been quite a number of practitioners of your colleagues that are going to a pharmacy and having customized concentrations created of 0.1 atropine, not a half percentage or 1% atropine. It's 0.1% atropine. And that appears to have similar effects without the side effects. So this is one of those stay tuned and let's see what happens, because maybe we'll find that a smaller concentration of atropine along with maybe contact lens intervention may be the tool. So we've got a number of tools that we can use to control myopia progression. We've got glasses, myopia control glasses from Zeiss, and we may have more on the market soon, that control the progression by about 30%. The soft multifocals tend to be just under 40%, Ortho-K at around 50%, and Atropine will need to follow the smaller concentration studies and just stay tuned on that one. So the question you might ask yourself is, what appears to be the best option for patients today? And I think we have some great options with both soft multifocals. They can be worn during the day. They're worn in a very safe environment in that way. We also have orthokeratology, which is also equally as safe, and we can control the myopia progression to a slightly larger degree. Now, how does orthokeratology work? If you've never used Ortho-K lenses, let's discuss how the treatment works exactly. Now, for the most part, the FDA-approved range for Ortho-K, not for myopia control, but for orthokeratology, is spherical prescriptions up to about 5 diopters, 1.5 diopters with the rule of astigmatism, and -75 against the rule sill. So your effective range for most conventional Ortho-K lenses is about 5 diopters of myopia. The Ortho-K lens is designed like this. You'll have base curve flatter than flat K, or flatter than the apical radii of the eye, and then that creates this reservoir of fluid that's trapped by the reverse curve that brings the lens back toward the surface of the eye. Then you have your alignment curve and your peripheral curve. So the Ortho-K lens works by riding on this layer of tear with this asymmetric shape of fluid. Now, what's actually happening underneath the orthokeratology lens? For the most part, we're making changes to the epithelial shape. Jennifer Chau's work, along with her colleague Patrick Caroline, showed us that the compression of epithelial cells creates our reduction in myopia, creates that flatter apical radius, whereas in the mid-periphery you get this thickening of the epithelial cells. So we don't actually move cells, of course, we just compress or flatten down the central cells, leaving the same number of layers of epithelium that we should naturally have. And then conversely, in the mid-periphery, we elongate the cells, create this extension of the epithelial depth. So another way to think about this is to do elevation maps. And what you can look at here is, this is comparing before Ortho-K to after Ortho-K. And on the graph here, 0 would be where the cornea was. And what we've done is compress the central epithelium by about 20 microns roughly. Remember that your epithelium is about 50 microns thick. So we've compressed those central cells. We've left the same number of 5 to 6 layers of cells. We've just reduced the elevation. Now, paracentral to that, at around 3 millimeters out, you see this increase in elevation. So compression in the center and increase in elevation paracentral to that. That's what creates the orthokeratology effect. Now, if you know that 20 microns is kind of that maximum epithelial change that we can create, then surely there must be limits to how much effect that we can create. And sure enough, the the lower the RX change that you need to achieve, the bigger the treatment zone can become. The smaller the treatment area, obviously, that would be associated with the higher myopic changes. So the higher the myopic ortho-K effect you create, the smaller the treatment zone. The lower the myopic change, the larger the treatment zone becomes. And that's seen here, where if we were trying to shoot for a 1 diopter effect, the treatment area may be quite large. When we go to a higher myopic change, we get a much smaller treatment area. So in the adult model, which is not the major area of fitting of these lenses, the high myopes with large pupils wouldn't be candidates for orthokeratology. However, in kids, it's probably a good thing. The larger the pupil, the more light is getting in there. That may create more of a signal, as well as having that plus in the peripheral pupil, creating that myopic defocus, not hyperopic defocus. Now this is the orthokeratology effect. You've got your astigmatic eye with your high eccentricity, your high rate of flattening, steepest in the center, flattest toward the periphery. Then by comparison, post-ortho-K, you see how you've sphericalized the pupillary zone, and that's what orthokeratology does. It takes a high aspheric cornea and turns it into a sphere. And a study by Mountford and Nowak quite a number of years ago showed us that the flatter the corneas, the lower the potential for effect. The steeper the corneas, the higher the potential for orthokeratology effect. Also, the lower the eccentricity, the lower the potential for effect. In other words, eccentricity measures the rate of corneal flattening. Zero eccentricity would be a sphere. So the higher the eccentricity, the higher the potential for ortho-K effect. So you want eyes that are steep and high eccentricity. They seem to respond best to orthokeratology treatment. Now this is the kind of profile of fluid that you would like to see under your orthokeratology lenses. What you're looking at here is the apex of the lens, the center of the lens, cut in half. And there's this tiny little fluid layer of about 5 to 10 microns underneath the center. And then in the mid-periphery, at about 3 millimeters out, you have this reservoir of fluid. And that difference between the fluid thickness here and the fluid thickness here creates a hydraulic effect. And that's how orthokeratology treatment is created. Ortho-K lenses do not work by mechanically compressing in epithelial cells. They work by hydraulically creating little tiny forces between lens and cornea, and that's what produces orthokeratology treatment. If your lens lands on the corneal apex, it would produce staining, and any ortho-K lens that's producing staining needs to be adjusted. Now this study by Mountford and Nowak showed us that if we put on various lenses on a patient to create different myopic changes, a 1 diopter myopic change, 2, 3, 4, and a 6 diopter myopic change, the central compression for all these lenses would be the same. So the central hydraulic force is identical no matter which lens type we use. However, if we're trying to achieve a mild little 1 diopter effect, we get this mild little tension force that exists in the periphery of the lens. So therefore, where the fluid thickness is greatest, that's where you have the greatest suction force. In the center, where you have that thin little fluid, you get a tiny amount of central compressive force. So by varying the apical thickness versus the fluid thickness in the mid-periphery, that creates different tension forces in the mid-periphery. The greater the tension force, the greater the myopic change in effect. So this is the ideal orthokeratology lens. That lens should look like central touch. However, the fluorescein molecules become so thin, under 20 microns, that you and I can't pick them up behind the slit lamp. So the Ortho-K lens should appear as touch, but not actually touch the central epithelium. When we remove the lens, we should not see staining from our orthokeratology lenses. Now, in the mid-periphery, what we're looking to see is this reservoir of fluid, and that creates the high peripheral corneal tension force, giving us that steepening in the mid-periphery, which flattens the center and creates steepening toward the peripheral part of the pupil and cornea. Then you have your alignment zone in the lens, and lastly, your standard edge lift that we want to see on any healthy RGP lens. So this is the pattern that we're trying to achieve. But to be honest, I rarely look at fluorescein pattern in Ortho-K lenses. They don't work in the open eye environment. They work in the closed eye environment. So sending the patient home with the lens and seeing what happens is what you want to do. And that's where corneal topography becomes key. You can only really have 3 outcomes from doing Ortho-K. Either the lens was perfectly fit and we get what's called the bullseye, the very well-centered treatment zone. If our lens is effectively too steep for the eye, then that may pull up the central epithelium, reverse the hydraulic force, and create central steepening rather than central flattening. And that's called the central island. So in that case, you would go lower in depth or flatter in lenses. If you have what's called the smiley face with the paracentral steepening inside the pupil down here and the treatment area appearing high in relationship with the pupil, then that's called the smiley face, and that's the opposite of the central island. That's a lens too flat for the eye that wants to ride high. Or the lid tension force is so high that it pulls the lens up, in which case you tighten up the alignment zone, neutralize that force, and bring the lens down. So here's a patient after 1 night in orthokeratology lenses. And this is the axial interpretation. What you see is a blue treatment area well centered to the black pupil margin. So we can say from 1 night in Ortho-K, our subtractive axial map is telling us that the treatment area is well centered. When we click our cursor in the center, this patient had a 2.2 diopter refractive change between the cornea before treatment and after treatment. So effectively, there's a 2.2 diopter reduction in their myopia. And you can see the type of myopia control shape that we create. Most effect in the center, less effect toward the periphery. Ortho-K does this by fluke. It was unintentional, but it actually serves us very well as a myopia control tool. Now the next map we use is the tangential map, and what you're looking at is this red ring where that hydraulic force is the highest, where that reservoir of fluid is the thickest. That creates the greatest tension force, pulling on the epithelium and creating the steepening. Now when you look at this map, would you say the red ring is well centered to the black pupil? If you argued anything, you might say it's slightly low, where the red ring is very close to the pupil up here versus maybe a ½ millimeter down here. But this is really a well-centered effect, so nothing we would complain about. Now here's the same patient after 1 month of wear in our orthokeratology lenses, and you see that treatment area filling in beautifully, and we still have that beautiful myopia control shape. Most effect in the center, less effect toward the periphery. And there's the tangential map. Again, we look at the red ring. Ortho-K full effect is 7 to 10 days. It's 7 to 10 days of treatment before you've achieved the maximum effect. So we go with 1 night to make sure we're on the right track, and then we have the patient go at least 2 weeks before we make a final call on do we need to make any adjustments here. And in this case, the lens is very well centered. That red ring runs fairly parallel to the black pupil margin. So in this case, this patient was able to wear their orthokeratology lenses every second night. It wasn't required that this patient wore their lenses every single day. My brother in Ortho-K wears his lenses once every 4 days. He's only a -1 myope. He's able to reduce his wear schedule to the point where Ortho-K is not a daily thing. It's more like a weekly thing where maybe twice a week he puts in his orthokeratology lenses. The question is, how often does each patient need to put their lenses in to maintain that foveal correction? The peripheral retinal plus that's created will automatically follow the central effect in lenses. Now, the BE Retainer is one of the lenses that we've used tonight to create some of these Ortho-K changes that we've seen. And the way the BE Retainer works is it's one of the designs that employs specifically corneal topography. You take your map, import it into a fitting software. That fitting software determines the candidacy for Ortho-K treatment, and it determines the initial trial lens. Then you send the patient home with that trial lens and evaluate the topographical response. So the BE Retainer system is very reliant on topography for determining the initial candidacy, determining the initial trial lens, and the final outcome, optimizing what actually happened. An advantage of the BE system is that the practitioner doesn't need to be heavily involved in the whole orthokeratology process because the technicians can often do the baseline topography. The technician can be trained to look at whether the patient is a candidate in the software. The software tells you good from bad candidates. Then lastly, the software will tell you what actually happened. So topographically, did you have the bullseye, the central island, or the smiley face? So it's a very exciting time, I think, in contact lenses, and an exciting time for reducing kids' myopia progression. We have orthokeratology, which appears to be able to control the progression by about 50%, soft lenses by about 40%. Our GP lenses, presbyopic or multifocal add RGP lenses are yet to be studied, but the same shape that we create in Ortho-K or soft lenses we can create with RGPs, so one would presume that it's possible. And the pharmaceutical intervention appears to be a powerful tool that if we can use the lower concentrations, if those study out, if 0.1% atropine studies out to be as effective as the higher concentrations, but without the side effects, then we've really got something as a tool along with the lenses as well. Now, if you're really interested in bringing orthokeratology to your practice, there's a workshop coming up in Vancouver, BC on January 10th and 11th. If you want to attend a Ortho-K lecture, workshop, and fish and ski in the same day, this is a conference that you can do it in Vancouver. Now, Patrick Caroline and myself from Pacific University will both be speaking at this event. Friday night will start at 6 p.m. That'll give you time for out-of-towners to make it into Vancouver. We're going to be fitting patients in the first hour. Then Pat will take us through myopia control techniques. He'll take us through a much broader look at the myopia control research that's been going on. And then the last part of that day will look at the different treatment procedures that you and your staff would need to go through to start Ortho-K with a patient and to do the initial overnights with the lenses. Then Saturday morning, we'll follow up with our patients in the AM and evaluate their outcomes as a group. Then we'll go through the science of orthokeratology and the methods to bring this to your practice. So the Friday 3 hours and the Saturday 3 hours will likely be COPE approved. The application was put in just a few days ago, so that will provide you with 6 hours of COPE CE. The next section from 12 to 1:30 is a non-CE section, and that will actually look at 3 different lens types and give you some perspective on which lenses you might use in your practice and the benefits of each, or possibly all of the 3 of them. Now, if you're from outside of Canada, this course will be beneficial for you from an educational standpoint. The lenses are available, the lenses we'll discuss at this workshop are available from the US. If you're from outside the US, most of these lenses are available internationally as well. So if you've joined us from Australia, or Europe or Asia, all of the lenses we'll discuss at this workshop should be available to you, but certainly from your local supplier you should be able to get these lenses. You're not bound to order from Precision Technology in Vancouver, nor should you consider ordering from Canada if you are not Canadian. Now, if you're interested in this workshop, there's a reduced pricing if you register before December 13th. So $200 if you're before December 13th, $250 after December 13th. Now, our next webinar on multifocal GP lenses for our presbyopes will take place on January 6th in the new year at 6 p.m. Pacific time. And if you are registered for this event, you will automatically receive an invitation for the next event. So for more information on anything we've discussed, either orthokeratology treatment in general, the BE Retainer design, the Medmont topographer, which is used as kind of the gold standard tool with orthokeratology, our multifocal GP workshop, or the Vancouver Ortho-K workshop in January, please don't hesitate to contact us either at the 800 line below or at the email you see, info@PTS Optics would probably be the best way to go. Now, in